Hello, everyone. Welcome again to one of our webinars. We're starting this month with holistic approach to pediatric therapy webinars, and we are very honored to welcome Miss Madhavi Adimulam and Miss Isha Singh from Ananya CDC today with us. Miss Madhavi Adimulam is a global top 20 Goldman Sachs fellowship winner. She's the co-founder and director of KidSense. KidSense is basically it assists child development in the critical first 6 years of their life when the interventions work the best and they enable the child to realize their full potential. That's what KidSense does. She's the founder of Ananya, an early intervention child developmental center, which started in 2007. She's a specialist in diverse educational needs with over 20 years of experience in autism spectrum disorder, SPDs, developmental delays, and ADHD. She's an expert in coaching and mentoring families of newly diagnosed children with special needs, and she's extremely skilled in doing awareness workshops and inclusion training programs for preschools and primary health and high schools. We welcome you, Ms. Madhvi. Thank you so much for coming in. Coming to our second speaker today, Ms. Isha Singh. She is a clinical psychologist with over 10 years of experience in clinical psychology, counseling, developing training courses for counselors. She runs workshops for communities on mental health and conducts corporate training on stress management. She does on personality development and enhancing leadership skills as well. She has practiced cognitive behavioral therapy with both children, individual adults, and couples. She has conducted psychometric assessments for neurological child and adult population as well. We welcome you, Ms. Isha Singh. Thank you so much for coming in. And from my end, I would really recommend all of you to go through their website, which is www.asap.org.in, because they have brilliant courses and workshops that they keep doing on and off with national and international speakers a lot. Over to you, Ms. Madhvi and Ms. Isha. Thank you.
Thank you. Thank you so much, Preet. Okay. So, hi, everyone. Good evening. Thank you for taking time out this time of the day after a long day at work. I'm sure some of your professionals and even parents, that's never ending work. Thank you so much for joining. I'd like to just, this is one of the reason why we started Ananya was to provide a very, holistic early intervention for children that was not available in Hyderabad uh, when I started. Now there are some centers that do provide some therapies or most of the therapies under one roof. So the whole journey started with my experience as a mother, of a child with ASD, and the struggles that I had gone through to get him the therapies that he needed. I remember when he was diagnosed. He's 22 now, so he was diagnosed when he was 2+ years old. That time in Hyderabad, we hardly had any places there where I could take Varun. I had, with great difficulty, had found one speech therapist, and within a couple of weeks she had left the country. So again the search began for me to get another therapist, and the search kept going on. And till I went to the UK, I did not understand that how these services need to be provided as a holistic thing, not as individual therapies. And child development needs to be looked at as a holistic thing, not as a single specialist at a time, but all specialists support the child during those the first 6 critical years of their lives. So that's what I have understood. And then I came back in 2007 to India, and I started Ananya with these kind of values in place. What are the kind of values that we believe in Ananya and should happen in child development? Most of the centers I see, most of the places that I visited in India, the safety aspect is most highly ignored. I'm going to talk about things that are not really core therapy related things, but I think these are very important for any center, making sure that the center is child proof, so to say. Can you leave a child alone for few minutes without the child getting hurt in the center? What kind of precautionary measures are taken about electricity points, or sharp edges of the tables? Are the table edges protected so that when children are running they don't hit on those edges? And what kind of safety measures are they taken care of? A lot of children with ASD have tendency to wander away. So what are the safety precautions that are taken in the clinic to protect that, the child's safety, and ensuring that the child doesn't wander during the therapy or after the therapy. In spite of so much protection, we still feel that some children are so smart that they just fool us and they try to escape from from the place. And also train the staff, like things like fire safety. What do you do if there is a fire in the building? What kind of first steps that the staff needs to be trained? Are the other staff trained to do first aid to children in the center? And also, how transparent are your therapies? We have ensured that from 2007, from the time we started, we ensured that every single therapy room is CCTV monitored. We don't leave any room that is unmonitored. We just ensure that wherever the child is moving around in the building, the whole place is CCTV monitored, so that nobody even thinks about harming the child. Even, they can't even think about it, because every angle is covered by cameras, so that the child's protection, safety is absolutely ensured. So these are some of the things that, I mean, I can go on and on, but these are some of the most important things, I believe, because of late I've heard some stories about some child development centers in Hyderabad where the child got abused and there was a police complaint lodged by the parents. I don't want any of those things to happen any child at under any circumstances. I think a special child is even more vulnerable to these safety issues when compared to typically developing 3 4 year olds, in early intervention age. So safety is first for us, and we ensure that all children who come to our clinic are safe. And respect, for me as a parent, it's very important that I address children as people first, not as diagnosis. I would never want to call the child autistic child, ADHD child, ID child. That kind of addressing I don't like. I would like to call the child the name of the child first, and the diagnosis happens to be later. I mean, like I'm wearing specs, so it doesn't mean that I'm myopic. Nobody calls me, oh, Madhvi, who's myopic. No, I see a lot of people calling children, oh, that boy, he's autistic, right? No, he's a child first, and autism just happens to be one thing the child has, not everything. And the child needs to be treated with dignity and respect when it comes to that. The diagnosis is just one of the things, and the diagnosis usually helps the specialist to help the child, not the child. you know it's for us to prepare his therapy plan, to deliver his therapy for him, to ensure that he achieves the milestones. We need to have that labeling for helping ourselves. We don't need to use that for helping the child. And also, respecting, many are things like not asking the child's permission before the child is dragged out of the room or dragged back into the room, pulling the child the way they like, and not asking the child his or her permission before they touch the child. you know can I help you with the with washing your hands? Can I do this for you? Can I do that for you? That kind of our culture is also not like that. We are a very ordering kind of culture. Our parents have ordered us, and we order our children, and then they will order their children. Teachers have ordered us. And especially when you are a therapist or in a teaching position, we tend to take that order as a giving order becomes a norm for us. We don't even blink our eye, we just order away. So thinking about whether the child wants it or not, whether the child wants to do it or not, can I take the child's permission before I do that? And ensuring that I'm present for the child when the child arrives for therapy. I'm on time. One way of showing respect is waiting for the child before the child comes and be prepared for the session. I tell all my team members that we need to ensure that we are present before the child comes. Ensure, have the plan ready, have all the material ready on the table, so that the child doesn't have to wait after the child comes, and ensure that you are ready for therapy. That's one way of showing respect, right? To say that you are important, that's why I'm ready for with all the information that is needed for you. I don't have to say that, but my behavior is speaks louder than my words. So if I respect the child, and I'm prepared for the session. If somebody tells me that they don't know, I would tell them to cancel the session. That's much better than to just bring the child over and just do some time pass with the child. And we are charging for that. So we don't have any right to take money from somebody who is Of course, from the parents, we don't have any right to take the money and then just do time pass and then send the child away. So that's absolutely important. And respecting other specialists. For instance, if I'm a speech therapist, I'm not, but I'm just giving you an example. Imagine I'm a speech therapist and trying to say that only my therapy is important. OT is not important, behavior is not important, any other psychological interventions are not important, only speech therapy is important. That kind of a behavior absolutely is not acceptable in our centers. Every professional who works with the child in early intervention is equally important. I don't want anybody to feel more important or less important. And also, speech especially happens to take the front seat because parents see speech as the first delay in children. They think that most of the children who come to us with any concern with their parents is because they have speech delay, because that's visible. Other delays are not visible to young parents. In case if it's their first child, they're clueless at all, totally clueless. So I would like to have this mutual respect amongst professionals and value each other's advice, value each other's suggestions, and also speak to each other. Many a times when I have just a single person, if I'm a speech therapist and I have a speech practice, I don't want to talk to anybody. I just want to do my speech therapy. Ideally, I should be talking to the OT, I should be talking to the psychologist, I should be talking to the parents, I should be talking to the school, and ensure that all these comprehensive observations are taken, and then I develop a plan for, you know, for the child. That's why I like the Hannon approach. So we love to work in a parent coaching model where the parent is always informed about what's happening to the child and how we can take parents help to achieve the goals for the child too. So respect comes first for us, then comes integrity. Integrity is something that a lot of us probably take for granted. Just because I'm in front of a camera, I behave in a certain way, and the moment I know that there is no camera, my behavior changes towards the child or towards my colleague or towards the parent. So behaving the same way, whether you are being watched or not, having the same behavior all the time of the day, whether you are being observed by your supervisors or the parents or by a CCTV camera, that's absolutely mandatory, I feel, because children can see through our behaviors very clearly compared to adults, I feel, especially if they are special children. I think they definitely have much more those extra perceptual skills that are so-called typically developing children don't have, because they can sense that this person is fake, this person is just showing off, or this person is just acting. So I don't want to go to this person. I've seen that a lot in special children. They know who to hug and who not to hug, who's just pretending that they are liking them. So I think integrity is very, very important, showing the same level of integrity. If a child is wearing dirty clothes, or if the child is smelling, if the child needs a diaper change, if the child needs to clean the nose, if the child has vomited, if the child has pulled your hair, if the child has you know uh, done anything that is uncomfortable to you, is your behavior the same or is your behavior changing? Because a 3-year-old does not know all that. And I tell all my therapists, most of them are very young, they don't have their own children. I tell them that imagine if you have a 3-year-old, they're most vulnerable, they really don't know anything about what's happening to them. If they have an autism diagnosis or whatever it is, they really don't know anything. But they are under your supervision. You're almost like a parent, like a mother to them in the absence of their mother. They depend on you for any help that they need during the absence of the mother. So do the best that you can. Call the, I mean, we have enough helpers here to help the children with whatever they need. I tell them that don't change your face, don't push them away, don't show any of those body language that children probably will pick up from you that is negative. So that's one important thing. So behaving the same way, whether anybody is watching you or not, is part of, I mean, one of the most important things for me. I think that speaks loads about your character as a person. you know and hygiene, especially due to COVID, I mean, I'm obsessed with cleanliness and hygiene. I always, I mean, especially the toilets that children use and, in the building. I think our children touch everything and they put their fingers in their mouth constantly. That really worries me because Due to COVID, hygiene has become even more important for us, making sure that the center is spick and span, the toilets are absolutely clean. And even if they're lying down on the floor of the toilet, it should be that clean. So cleaning the toilets multiple times, ensuring that the children's hands are sanitized, and the whole building is clean, or the whole whatever, however big your clinic is, keeping the clinic clean, and in talking to the parents, many a times I had to call and speak to parents and tell them that send a change of clothes. It appears as if the child has not taken bath or brushed his teeth. If the first session in the morning, sometimes they just wake up the child and bring the child to the clinic because they don't want to miss the first 10 minutes, or they woke up late. So I tell them, more than that, I think for me, child's hygiene is important. How the child feels when the child comes to the center. What kind of clothes is the child wearing? Is he coming in a pajama? I remember we had a parent who used to bring the child every morning in pajamas to the clinic, and the child would just wake up half asleep, come to the clinic, because both the parents used to work, and they would just bring the child in the pajamas. And when I asked the parents, they used to tell things like, we gave him bath in the night, so mornings he doesn't take bath. We brushed his teeth before he went to bed, so we don't brush his teeth in the morning. Things like that. So it used to really bother me, and I had to really call them and make them sit and understand that it's not just for saying that I brushed my teeth and I took bath. How does the child feel, just waking up from the bed and directly coming for therapy? And most of the time, the child used to do potty at the center after coming. So first half an hour used to go for his potty. I said, you are paying us for consultation, I mean, for therapy, and the child spends most of the time in the potty. What kind of therapy can we do in the potty? So hygiene, I mean, a lot of young parents nowadays don't even seem to know many basic things that I would just assume parents would know, because of whatever, no adults, no seniors in the house, like grandparents in the house, to guide them, to advise them what is good for the child. I think we also double up as that for parents. They expect us to give parenting advice, health advice, everything. They ask me, they call me and say, ma'am, this is what is happening. So really, they don't know where to go to, so they look to us for help. So hygiene and COVID norms, we were open most of the times during the COVID time. First 1 month, I think 3 weeks or so, we couldn't open because of the sudden lockdown. We didn't understand the process, but after that, we never closed. We were always open. Even when during the peak COVID time, we were working in Ananya, and those parents who wanted to come, we said, you're welcome to come. We got them permissions, but we ensured that the building was spick and span. We followed all the norms and cleaning norms, and we spoke to the doctors, we spoke to everybody, and ensured that those things are in place. So I don't know how many hundreds of liters of hand sanitizer I've purchased over the last 2 years for the center. And yes, so we had to follow so many norms for hygiene. So that comes, I don't know, I think all these come on the same pedestal level. Just because they are in an order of 1, 2, 3, doesn't mean that one item is less than the other, or one value is less than the other. For me, all these come on the same level. And as a person who runs the center, I would like to focus on all these things at the same level. So, I mean, that's my perspective from a founder's perspective, how I want my center to be. If it's a holistic center, how I want it to be. And I hand over to Isha for her session now.
Okay, thank you so much, Madhavi, and thank you so much, Preet, for giving us this opportunity. So I wanted you guys, I was talking to Preet before the session, and I asked her the question that who are the participants? Are they professional or the parents? My whole concern about asking Madhavi to go through these things were because as a young professional, I think I have not updated my LinkedIn for a long time, because it's been 15 years in this profession now. So in the last 15 years and the few years that I have been at Ananya, I have worked like in a government setup, I have worked in a corporate setup, and I've worked here in a private sector setup now. Some of the things that Madhavi was mentioning, it is very, very essential before you start diagnosing or before you start the intervention of the child. Most of these things, unfortunately, is not followed in the government setups. And please believe me, without taking names, 2 years I mean, day in and out, I have been stationed in government hospitals. But maybe because of the number of patients or number of children that they see, or the stress of the job, or I don't know what it is. Actually, I can't pinpoint. But a lot of us do not follow or become a part of the system and do not follow these basic things that needs to be followed before we label a child with any of the childhood disorders, or we start intervention with the child. Try and understand something when I come to intervention, or in fact diagnosis also. How can I diagnose a child when there are 10 children around him or her, actually, right? I mean, how is it possible to observe the behavior of the child? How is it possible to validate or to be reliable that the behavior is right, the behavior is an issue or a concern, when there are 10 other children distracting him or her? So diagnosis in itself becomes a question. The intervention that we plan is based on the diagnosis, based on the symptoms, right? So how are we sure that the therapies that we are planning, the intervention that we are planning is right? So all these, respect, integrity, hygiene, I mean, the whole environment makes a huge difference when we are talking about intervention of a child, diagnosis and intervention of the child. So yes, that's much more important than giving an autism diagnosis to the child. Okay, now some technical stuff for the professionals especially. So WHO estimates that 10% increase on adolescents experience some mental health concerns, right? So I mean, it is so much of an increase now. 10% is a huge number. Believe me, 10% is a huge number. So when we are talking about early intervention, the diagnosis has gone from 2 years to 3 years to 1.5 years. The developmental delay that we see now in our clinics is as young as 1.5 years. And autism can be diagnosed at 1.5 years. We do, as professionals, wait till 2 years to diagnose a child, right? But still, the symptoms can be seen at 1.5 years of age. And that this, I am so, in last 15 years, this has not changed. This statement has not changed. That frequently it has been seen that due to a delay in identifying any lag in achieving the development milestones, the child does not get the timely support required. So when the child comes to us, right, at 1.5 years or 2 years of age, generally parents seem to have a concern that the child is not speaking. That is the first concern that most of the parents come to us for, that the child is not speaking properly or is stuttering or the speech is not clear. So at this stage, in mild to moderate conditions, it is still at a concern stage. It is not a diagnosis stage. But a lot of parents, because it is just one developmental milestone that has not been achieved and others they are not aware of maybe, or they just take it for granted that the child would be able to achieve, they wait for years and years and years, till 5 years maybe, till 6 years maybe. And then they come to a professional, right? At 6 years of age, most of us know that the personality, the developmental milestones of the child has been almost solidified, almost like a foundation has been made. So it becomes very difficult for us to do anything with the child, to have an intervention where we can help the child as we could help the child when he or she was 2 years of age, right? So that becomes very, very important in early intervention. Right? When the child comes to us, at least to intervene early. So you can teach the child, you can modify the things, modify the behavior, teach the child the right thing, like from adaptive skills to life skills, to speech therapy, to fine motor skills. All those things can be taught to the child, right, at time. So, I mean, if you see it in the continuum, the development turns into a disability, a childhood disability, because we do not give help to the child on the right time. Therefore, the diagnosis comes later, right? And this is completely to the mild to moderate stages, not in the severe stages, right? Okay. So how do we do? Again, it's a little technical, but when the child comes to us, when the parent walks into the clinic, what do we do? First and foremost, contact with the parents is you as a professional, right? So what do you ask the parent? You don't ask the parent, I mean, in 15 years, I've never asked the parents, what is wrong with your child? Or why have you come to us, right? I mean, that as a parent, I would be really offended if somebody asked me like this, right? So we don't ask the parent that. We ask the parent, how do we help you, right? What are the concerns that he has got you to us? Because try and understand it, India still, the stigma related to childhood disability, childhood disorders, psychologists, clinics, hospitals, a mental health institute is still a lot. Right? So the fact that the parents have come to us, that means they must be seeing the delay in the development or something wrong with the child for some time now, right? And they can't correct it or they can't fix it as most of the parents think, right? So therefore they have come to us for help. So that becomes very, very important. In parent consultation, people feel that it is just like a questionnaire kind of a thing. So why is it important? But parent consultation is very, very important. So one of the things that you can ask when you can assess is the relationship of the child with the parent. How parent treats the child. What are the symptoms or the concerns the child has been facing for a lot of time? Because most of the time the child doesn't come to us, the parents come to us. That will tell us how observant the parent is, what kind of parenting the child is having. Did the parent wait for 5 years to come to us and to find out there's something wrong with the child, or there's something that needs to be fixed or something like that? So that is very, very important in a parent consultation. We do ask the primary symptoms, right? Primary as in the triggering factor that why the parent has chosen to come to us at this particular time and not 5 days before. This could tell us more about the social stresses, the psychosocial stresses, or something that has happened, or something geographical change that has happened that is related to childhood disability. And try and understand something more. There's a neurological aspect to childhood disorders, definitely. There's a genetic aspect to childhood disorders, definitely. But there's a sociological aspect to childhood disorders also, right? For example, during the COVID, the children were already in small houses, in the rooms. They could not go out downstairs to play with other children. So the social interaction was less. Their fine motor skills, gross motor skills did not develop a lot. Their communication did not learn a lot of communicative skills also. So a developmental delay in itself is seen a lot in such conditions. Therefore, a sociological or psychological aspect to childhood disorders becomes very, very important. And that can be figured out when you're doing a parental consultation, right? Okay, the origin parent caregivers becomes more informed source. So in neurological aspect, because childhood disability has a genetic and a neurological aspect to it. So the origin, when did the concerns start? It becomes very, very important, because genetically either you can see the pattern or you can see that there is a neurological aspect and it has been right from the childhood. So then the treatment plan needs to be performed like that, then planned like that. That's why it becomes very, very important. Okay. So history technique and MSc, detailed history. I can't stress enough. History is very, very important when you're talking to a child, right? Because the child will not be able to tell you what he or she is feeling or going through, at least till 5 to 6 years. They're not able to say, right? I have a 6-year nephew. He still, when I ask him, why did you do such a thing, or why you are feeling like that? He has no clue. He just says, okay, I'm feeling like that. I just wanted to do like that. So it's very difficult for children to express or to rationalize logically why they are doing something, or when they are in pain or something like that. So history becomes very, very important when you're dealing with a child, when you're working in a child development center, right? And it can be done by any professional. It's not like as a clinical psychologist, I need to take the history. A speech therapist needs to take a history of speech, or OT therapist has to take a history, complete history, that if there has been a delay in above generations, in the mother's side, in the father's side. And it's not to pinpoint that there's something wrong with the mother's or the family or the father's side. It's not that. It is just to see what is the genetic connotation to it, right? Therefore, history becomes very, very important. Mental state examination. MSc is mental state examination. Mental state examination is used like professional like us, like a clinical psychologist, to diagnose a child also. In the absence of a formal psychological assessment. Mental status, you can find out the memory of the child, the attention of the child, the concentration of the child. I don't need a corners to tell me if the child is an ADHD or not. I don't need a DP3, or I don't need a CARS2 to tell me if the child has autism or not, right? If the child has a global developmental delay or not. MSc is more than enough for me. And MSc can be done again by any of the professionals. It doesn't need to be a clinical psychologist, right? Clinical psychologists are needed in India to give a diagnosis, right? Not to do these tests. Anybody can do. So I actually tell the professionals here at Ananya, right? Please go ahead and assess the child. You don't need me completely there in the room. Okay. Okay, so planning a psychological, after having a history and doing an MSc with the child and consulting with the parents, you have a brief idea what you're looking at. I mean, if it's 15 years of experience, I do have a brief idea and a diagnosis in my mind that what am I looking at. But we need to have a structured way when we do a assessment with the child. We can't just assess the child, or we can't do assessment with the child on our whims and fancies. Okay, I just feel like doing corners 3, so I did that. The child does not have any attention or concentration symptoms. So why am I assessing the child for ADHD? No answer, right? So I do have a structure. We always, after getting all the information from the parent, from the child through MSc, we plan the assessments properly. So first assessment that needs to be done with your child is a developmental assessment. No psychological, no psychometric assessment can be done before performing a developmental assessment with the child. Right? Development, we at Ananya do DP3, but DST can be done, Denver's can be done. All these screening tools can be done. Basically, we have to see in that developmental assessment which milestone of the child is delayed, which needs to be assessed more in detail, and which does not need to be assessed in detail so much. For example, if the child's speech has come big time delay, but the physical aspect has come almost age appropriate. So I know that I need to dwell and talk to a speech therapist and dwell on speech assessment more than on OT assessment to some extent, right? Fine motor we still can do, of course, but gross motor still. So that kind of a comparison can be done. But we have to start assessment. We have to start the assessment with a developmental assessment of the child. Then a specific assessment of various milestones, as I said, a speech, OT, cognitive, neurological, if that needs to be, that is a memory, right? Memory, we assess the memory of the child through NIMHANS. We do any of the, I prefer NIMHANS, so we do NIMHANS generally. So we do the PGI memory scale is also a very good scale to assess the memory of the child. So these neurological assessment, then comes to emotional assessment, that's the TAT. In some cases, Rorschach, but I do not prefer personally Rorschach with children, but TAT, that is thematic apperception test, and CAT, that is a child apperception test. Both are a very good measure of what psychological stress or emotional stress the child could be going on. And believe me, there is a huge component, as I said, maybe the child has just shifted 6 months back. Therefore, the symptoms have started. Maybe because of COVID, the child is feeling very lonely. So the depressive symptoms or the behavioral symptoms have started. Depressive symptoms does not mean depression. Depressive symptoms means that the child is being alone or getting a lot of aggression in his or her behavior, right? So depression or depressive symptoms is very different when it comes in adults and when it comes in children. So that emotional assessment becomes very, very important. Last is the diagnostic assessment. In India, I've seen a lot of times it's the reverse. First, we do a CARS 2, right, and diagnose a child with ASD or maybe a Connors 3 and diagnose a child with ADHD or an LD, right? And then we do the other ones. It has to be always reverse. We have to start with a developmental assessment and then various milestones in details, neurological, emotional, and a diagnostic assessment, right? I mean, at Ananya, we take around 4-5 days to do all these assessments, like 10 hours, 12 hours job. The child goes to each of the therapists, right? And then we do all the assessments together. So in summary, as Madhavi was mentioning, that's very important to talk to other professionals, right? So for example, I see the child for the first day, I'm doing a consultation with the parent and I see the child for the first day. So there are some things that I notice, right, when the child has come. The child is aloof or is very irritated, is always clinging to the mother and the father. That can very well be because the child has come to the clinic for the first time. It's a strange place, it's a new place, I'm a stranger to the child. The child may very well behave like that in my presence. But on the 6th or the 7th day, right, when the child is there in the OT room playing with other children, maybe the child has become more comfortable. And what I observed is not relevant to the 6th or 7th day. So I need to talk to the therapist then. I need to talk to the OT there. I need to talk to the speech therapist there. That have you seen the same thing that I have observed? That is very, very crucial in a diagnosis of the child, right? It has to be similar. The symptoms has to be similar. It can't be just one day because we are diagnosing one of the criteria of DSM is that it has to be pervasive. Right? It has to be long term. It doesn't have to be just one day. Right? So that's why it's very, very important when you're summarizing that all the therapists, all the professionals that has seen the child have had the same observations with the child, right? then you conclude that if, okay, so all the therapists, all the professionals have the same conclusion, same observation, then what is the conclusion? That the development is delayed in these categories, and this is the reason of the delay, right? Could be the reason, maybe, right? A provisional thing. And then the diagnosis. So all these symptoms refer, all these symptoms look at, all the symptoms may seem like that the child can be diagnosed as one of these childhood disorders. So this is briefly how we follow right from a diagnosis to the intervention of the child. And then you plan, of course, the different kind of intervention of the child, be it speech therapy, be it OT, be it Hannon's protocol that she said. All these things can be done with the child, or a cognitive therapy, or a behavior therapy, pure behavior therapy, or social skills training, also adaptive skills training, life skills training. All these can be planned only by getting all these informations together in the form of a psychological report. Okay, so thank you very much.